Question number 1. 50-year-old Chinese guy with chest pain. The right-sided ECG leads are actually normal. Where is the lesion? So is it in the proximal or distal LAD, proximal or distal circ, proximal or distal RCA, or is this acute pericarditis? Large proportion of people think it's in the proximal RCA. And we'll come to the answer in the next parts. So we all know that there are two main types of myocardial infarction, the ST elevation myocardial infarction and the non-ST elevation myocardial infarction. And it's actually good to understand the first principles of why one type of heart attack causes a ST depression and one causes a ST elevation. If you have subendocardial injury, meaning that not the entire muscle wall was infarcted, your vectors of depolarization is actually inwards. And as such, you get the ST depression. Whereas if you have a full transmural infarction, the vectors of depolarization is actually outwards, and you get your ST elevation. And so in this ECG that we saw earlier, I think the majority of people can recognize it's an inferior ST elevation MI. And when we come to a case of an inferior ST elevation MI, we need to ask ourselves a few questions. One, we need to ask ourselves, what is the rhythm? Because we know that heart blocks and rhythm abnormalities are more prominent in the inferior ST elevation myocardial infarction. Second, we need to ask ourselves, besides the inferior injury, is there posterior involvement? And how we do that is we look at leads V1 and V2, or we put on new posterior leads, and we'll come to that in a while. Next up, besides posterior involvement, we have to ask ourselves, is there RV involvement? And that's when we do the right-sided leads. And very lastly, more for interest, for those who have a deeper interest in ECGs, you can ask ourselves, is this inferior ST elevation caused by a right coronary artery occlusion or left circumflex occlusion? And how do we tell the difference between a RCA or left circumflex lesion? So we all know that this is the Einthoven's triangle, whereby your limb leads 2, 3, and 1. 1 is facing this direction on the right, if you can follow my pointer. And the inferior leads 2 and 3 are pointing downwards. We know that the RCA comes from the right side. So if you follow my pointer, it comes over this way. And the circumflex comes over from the other side, the left side. So it's this way. So in general, if you have a right RCA infarct, if you come here, because the RCA comes from the right side, your leads 3 will tend to have a higher ST elevation than the lead 2. This is one pointer that you can kind of look at. For the circumflex, it comes over from the left side, this way. So usually, the ST elevation in lead 2 is higher than that of lead 3. In addition, your lateral leads 1 will tend to show some ST elevations. So let's come back to the ECG that we saw earlier. This gentleman presented with chest pain. I mentioned that the right-sided ECG is normal. Where is the culprit vessel? So if you analyze this ECG, I think the most stark abnormality is that there are ST elevations in 2, 3, and AVF. In this case, if you count it exactly, the ST elevations in lead 3 is slightly more than lead 2. So this hints a little bit more towards the RCA involvement rather than the circumflex. And there are a few other things that we want to look at. We look at V1 and V2. You can see deep ST depressions. And we know V1 and V2 looks at the anterior part of the heart. If you have ST elevations, if you flip it over, it's actually, ST depression, if you flip it over, it's actually ST elevations in the posterior lead. So that's how we know that there's posterior involvement. Look at the lateral leads, you see reciprocal ST depressions. Once again, pointing more towards right coronary artery involvement rather than the circumflex. Importantly, on the right-sided ECGs, there were no ST elevations. As such, the site of the occlusion will be more in the mid or distal RCA after the RV branch. So that's how we come to a conclusion that this is a mid-distal RCA occlusion. Let me show you an example of a left circumflex artery occlusion. This is the ECG on the right. It's from a patient who had a circ occlusion. Once again, you still see ST elevations inferiorly. But in this case, the ST elevations in lead 2 are more marked than in lead 3. And if you look at the lateral leads, V5, V6, there are ST elevations in the lateral leads. We know the circumflex comes from the lateral side of the heart. And all these point towards a more towards a left circumflex occlusion. So I want to summarize what we have talked about, so that for everyone's understanding, we know that the leads are placed V1 to V6 on the anterior chest wall. This looks at the axial plane of the heart. Okay, and then our lean leads look at the coronal segment of the heart. And so, in this summary diagram here, it tells you what to look out for if you have an inferior MI, what are the lead changes, inferior posterior MI, what are the lead changes. If you have a more anterior kind of MI, it involves your V1 to V5. And then once again, the different changes to be expected in the different kinds of heart attacks that you get. Just a quick shout out to one of the apps that our National Heart Center has designed. A group of clinicians from our institution have actually come up with this ECG app. You can find it on the App Store or Google Play. It's free for download. It has a lot of interesting clinical posts as well as cases on ECGs in ischemic heart disease, tachycardia, bradycardias, and then there's also quite some quizzes. It may be quite useful for learning. Okay, thank you.